start this morning by offering you a little bit of free advice. I don't have any illusions about how many people take my advice and how many ignore it. My own daughter went to medical school here a few years back, and I used to tell her after birth or right at birth. And all I intended to say was what's in your lecture outline. But what I found is that when I looked at the dental board exam, there were some fairly detailed questions about the fetal circulation and changes that occurred at birth. So I want to go into a little bit more detail at this time because it's related to this vasoconstriction induced by hypoxia. Over here on the blackboard, I have jotted down in a very succinct form really about the only thing you need to note. But I'm going to show you a slide that's not in your lecture outline. If you look at the blackboard over there, you can see what I sketched up was that in the fetus, there's a connection between the right atrium and the left atrium, and that connection is called the foramen ovale. There's also a connection between the pulmonary artery and the aorta, and it also has a Latin name, the ductus arteriosus. So that's really about the only note you need to make in order to get those questions right that were on the dental board exam. But if we look at the slide, you can see that what's going on in fetal life is that the oxygenated blood comes from the placenta, and as it flows back to the right side of the heart, instead of going through the lungs, it takes advantage of these bypass vessels or shunts. And so let's look at the first case. Some of that blood flowing back to the right side of the heart, instead of going through the lungs, passes through the foramen ovale into the left atrium and then into the left ventricle and gets pumped out into the systemic circulation. So it has effectively bypassed the lungs. And during fetal development, the lungs get very little blood flow, not anything like the full cardiac output that they would get after birth. The other route is that this oxygenated blood from the umbilical vein will flow into the right side of the heart, go on to the right ventricle, get pumped out of the pulmonary artery, and then take this shortcut through the ductus arteriosus to the aorta. So these two connections essentially represent shunts or bypasses so that the blood flowing through them short circuits, doesn't go through the lungs. And of course, what happens at birth is that when the baby takes its first breath, you have had relatively hypoxic conditions in the lung, but now you have some nice fresh room air coming in, raising the oxygen level, which causes vasodilation. So here's the opposite effect. You've eliminated the hypoxia with that first breath, raised the oxygen level, and the blood vessels in the lung vasodilate. And so what happens with the first breath is that blood begins to perfuse the lung because vascular resistance drops as that air is brought in. And then over the next few hours or days, the foramen ovale closes and the ductus arteriosus closes. And actually the ductus arteriosus can persist, which is abnormal. It's called a patent ductus arteriosus, meaning open. And in this situation, it can be an abnormal shunt if it persists, say in a newborn baby for the first few weeks or for the rest of his life. And in fact, there are actually adults walking around in their 50s and 60s who have congenital heart defects that haven't been diagnosed yet. There's actually a subdivision of cardiology that deals with congenital anomalies that are first diagnosed in adulthood. Now, so far what we have talked about are regional differences in blood flow or perfusion that occur in different portions of the lung because of the effects of gravity. We now want to turn our attention to regional differences in ventilation or airflow, and again, this is an effect of gravity. So what this sketch depicts is a lung in someone in the upright position, standing or sitting upright, so that this would be the top of the lung up here and the bottom down here. Now, whenever you teach or write a textbook, you have to start off by telling a lie or two. And the lie is usually an oversimplification. What I hope you will remember is that I told you earlier the intrapleural pressure was negative and it was about -5 centimeters of water, or as your textbook says, about -4 millimeters of mercury. In actuality, the intrapleural pressure varies from top to the bottom, and what I gave you and what your textbook stated was just sort of an average value, -5 centimeters of water. If we look more closely, what we would see is that the intrapleural pressure outside the lung, up here at the top, is very negative, like -10 centimeters of water. And as we go down to the bottom, it comes up closer to 0, so down at the bottom here it's only about -2 centimeters of water. And so in this position, the effect of gravity is to push down and compress the lower portions, the dependent portions of the lung. It's pulling away from the pleura up here because of gravity, leaving a more negative pressure up here, but it's more compressed and pushing downwards here, so it's less negative. Now, that's all just kind of interesting and esoteric, but it has a very important effect. If we go back and look at the pressure volume curve, you remember that plotting volume versus pressure was a way of exploring the so-called compliance of the lung. And so if we look at this portion down here at the bottom with this intrapleural pressure of -2.5, that would put us about down here on the so-called pressure volume curve. Now, what do we do to inhale? Well, the lung is already in a vacuum, so to speak, and by inhaling we make it more negative and draw air in from the outside. So if we start down here at this -2.5 centimeters of water and we take the intrapleural pressure a little more negative as we inhale, the volume will go up from this point here to the end of the arrow there. And that's a relatively large change in volume, and a change in volume per unit time is flow. So the airflow at this portion should be pretty large. Now, if we go up and look at the top of the lung, which has this -10 centimeters of water in the intrapleural space, that means that the top of the lung is operating from a different starting point on the pressure volume curve. So this point right here would be its starting point at about -10 centimeters of water. Now, if we then try to inhale and we make the change in intrapleural pressure the same as when we did it down here, this arrow would show you the change in volume starting at this point and reading off the axis, going to the arrowhead and reading off there. That's not as much of a change in volume as it is down here. And as I just mentioned, a change in volume per unit time converts into flow, in this case airflow. So the conclusion we'd have to reach is that because the top and the bottom of the lung are operating on two different parts of the pressure volume curve, the ventilation at the bottom down here would be greater for the same change in intrapleural pressure than it would up here at the top of the lung. So the ventilation would be greater at the bottom than at the top, and it's merely a result of the fact that gravity acting on the lung is tending to compress it towards the bottom, make it more compliant, and in fact the slope of this line has the units of change in volume over change in pressure, and therefore satisfies the definition of compliance. So this relatively compressed portion at the bottom is operating from a steep portion of the pressure volume curve where the lung has a relatively large compliance. By contrast, the top of the lung is operating on a portion of the pressure volume curve that's not as steep and therefore won't be as well ventilated for a given change in intrapleural pressure. So those simple definitions we went over at the very beginning can come right back to either haunt you or to let you apply them and understand a new concept. So what we've seen at this point is that there are regional differences both in blood flow and airflow as you go from the top to the bottom of the lung. And in both cases, the air and blood flow are greater at the bottom. Now we come to the challenge, and that is coming to grips with this concept of the ventilation to perfusion ratio. Many people call it the VQ ratio or the VAQ ratio, but it has come to be an extremely important concept in pulmonary physiology and medicine. Now, at first glance, I think it's quite simple and straightforward. Here you have some typical average values for various variables in the lung and pulmonary circulation. I hope some of these numbers are becoming familiar to you. You have a tidal volume of about 500 milliliters per breath. The dead space that it goes into constitutes about 150 milliliters. The respiratory zone of the lung has about 3 liters or 3,000 milliliters in it. And in the case of blood flow, we've got our old friend, the cardiac output of about 5 liters per minute. So if we calculate the airflow, the effective airflow, which is the alveolar ventilation, it works out to be something similar to the blood flow. Now, this is another figure that varies a little bit from one textbook to another. I think your textbook has the alveolar ventilation between 4 and 5, close to 5 liters. This author had it a little over 5. But if we take the ratio of ventilation to perfusion or blood flow, it comes out approximately 1 to 1. So this would be the concept, the ventilation to perfusion ratio, and we just start out by looking at alveolar ventilation to the whole lung and the cardiac output or blood flow, the perfusion of the entire lung. So looking at it just from the point of view of the whole lung, it's a ratio of airflow reaching the alveoli to the blood flow perfusing the lung. Now, here's a graph that usually requires careful study. It shows 2 things that we've already noted in the previous slides. We're using this horizontal axis to go beginning on the left from the bottom out towards the top of the lung. And the 2 things we've already encountered is that the experimental data show that blood flow is greatest at the bottom and it falls off as you go up towards the top. We've also seen that ventilation is greater at the bottom and that it declines as you go up towards the top of the lung. But these 2 lines have different slopes. Blood is pretty dense and the effect of gravity on blood flow is greater, and so this is a pretty steep curve here. But we can approximate the data by just using straight lines. Now here's the trick. When you do a little bit of math, things can get interesting. If we take the ratio of ventilation to perfusion, and that's plotted against this axis over here on the right, you can see that as you go from the bottom to the top of the lung, the ventilation to perfusion ratio starts out low, it increases gradually, and then it increases sharply as you go up towards the top. And this is essentially just the way the math would work out. If we start off at the bottom, where the blood flow is relatively high, and so is the ventilation, but it's less, then when we take that ratio, putting ventilation over blood flow, we get a ratio that's less than 1. And then as you go from the bottom towards the top, the blood flow is declining, so is the ventilation, but not as steeply, and we reach a point where the 2 are the same, and so the ratio is 1. Then when the 2 lines cross each other, we're still putting ventilation in the numerator and perfusion or blood flow in the denominator, and so now the ratio becomes greater than 1. And it's just the nature of the math. When you take a ratio of two linear functions, you get this curve. So in this case, what was probably counterintuitive is that we knew blood flow and ventilation were greater at the bottom, but we didn't probably expect that the ratio of ventilation to perfusion would be greater at the top than at the bottom. And as again, I think it may take a little while of going over that before it fully sinks in. Well, who cares? Why do you care what the ratio of ventilation to perfusion is? Well, one good reason to care, as I mentioned at the beginning, was that there are 4 different causes of inadequate oxygen in arterial blood, but the most common way that pulmonary disorders cause inadequate oxygenation of arterial blood is through a mismatch between ventilation and perfusion. And that's why the ratio is important from a clinical point of view. Well, what consequences does it have, and why does it produce inadequate oxygen? This is a slide that came out of the lecture on alveolar ventilation, and I'm putting it up just to remind you of a couple of things. When we considered alveolar ventilation, we said in this case the independent variable is the ventilation. You could imagine us asking a subject to just huff and puff voluntarily and increase his alveolar ventilation. And we could look at the alveolar PO2 plotted on this axis. And so one of the points I made back during that lecture was that as you increase your alveolar ventilation above normal, you start at an alveolar level around 100 to 105, and as you increase alveolar ventilation, the alveolar PO2 increases, and if you could really huff and puff, it would approach the value in the room air you're breathing. So 150 millimeters of mercury is approximately the PO2 in the air in your trachea that's humidified, assuming you're at sea level. So an infinite amount of ventilation would make the PO2 in the alveoli approach the level in the air you're breathing. In the case of carbon dioxide, we start at a normal alveolar PO2 of about 40 millimeters of mercury, and if we huffed and puffed, we could bring it down, further down, and if we could really get our ventilation going, we could bring it down to 0, which is a concentration of CO2 in the air you're breathing. So in both cases, infinite alveolar ventilation or extremely high alveolar ventilation would cause both the PO2 and the PCO2 to approach the value in room air. So what role then does the ventilation to perfusion ratio play? Well, this little sketch here gives you a pretty good idea. This line here is supposed to represent the VAQ ratio, as it's affectionately known, ranging from 0 to infinity. That's not a proportional sign. It didn't close it up there. It's an infinity sign. And so if we look at the effects of this ratio, I think you'll agree that taking it from 0 to infinity should cover a sufficient range. Now, let's look at the example where it's 0. This is depicted over here in sketch B. No, I'm sorry. Wait a minute. Yeah, that's right. Here's sketch B. There's no ventilation. This symbolizes the airway is blocked off, so there's no ventilation. So if we put 0 in the numerator, then obviously the ratio is 0. In this case, we have blood flowing through this lung unit, but we're not getting any airflow. It's blocked off. So what happens? Well, in mixed venous blood, the PO2 is about 40, and the PCO2 is about 45. And so this lung unit equilibrates with the mixed venous blood, And the gas here in these alveoli has the same composition as the mixed venous blood, PO2 of 40, PCO2 of 45. And that would be a VAQ ratio of 0. And by the way, when you have questions about this, my advice is make this little sketch. You know, if I ask you a question about a low VAQ ratio and its effects, 0 is pretty low. Make a little sketch and think it through. Now, let's take the other extreme. Let's say that the ventilation to perfusion ratio is infinite or approaching infinity. In this case, we've got a real number in the numerator. We're ventilating this lung unit, but this depicts the blood flow being blocked. So we've got 0 in the denominator. So as the denominator approaches 0, the ratio approaches infinity. But again, it's much simpler to think of it as, okay, if that's the case, then let's have airflow going on, so I've got a real number in the numerator, but we block the blood flow and the ratio approaches infinity. Well, what happens in that case? This lung unit equilibrates with the room air you're breathing. The PO2 comes up to the 150 in the air you're breathing, and the CO2 gets eliminated and it falls to the concentration in room air, a PCO2 of 0, just like the room air you're breathing. And there's no blood flow to change those values. So I think the easiest approach is to start at the extremes. Think through what it really means and what the consequence is of having a ventilation to perfusion ratio of 0, which means you have no ventilation, it's blocked off, but the blood flow is continuing. Then the next step is go to where the ratio approaches infinity and to say, okay, now I've got ventilation going on in the numerator, but blood flow is 0. And then it's pretty clear that in this case, with no blood flow, the ventilation brings you up to the same concentration of gases as room air, whereas in this case, with no ventilation, the venous blood coming in equilibrates, and the gases in the lung unit are essentially the same as in mixed venous blood. And where do we operate normally? Well, if we have a good balance between ventilation and perfusion, if they're reasonably well matched, we'll have the values that you're familiar with. The lung unit will have, or the alveoli will have a PO2 between 100 and 105, somewhere in that ballpark, and the CO2 will be about 40 millimeters of mercury. Of course, as we've seen before, what's happening is that the mixed venous blood coming in with a PO2 of about 40 is taking on oxygen because of this difference, and when it leaves, it has the same PO2 as the alveoli. Similarly, the CO2 in the mixed venous blood at 45 is being delivered by blood flow. It diffuses into the alveoli, raising the PCO2 from the 0 in room air up to about 40, and so the arterial blood leaving has a PCO2 of about 40. So there would be your normal situation where you have an optimum balance between airflow and blood flow. Now, this is a graph that's called the O2-CO2 diagram, and I find it something of a really unique and almost miraculous way of looking at things. What this curve shows you is that if you're breathing ordinary room air and your mixed venous blood has the usual composition, then this line describes every possible combination of PO2 and PCO2 you could have. Let's see how it works. Well, if the ratio of ventilation to perfusion is infinite, that is, you have ventilation going on but no blood flow, then this lung unit equilibrates with room air, and the PO2, sure enough, is 150, and the PCO2 is 0. Going to the other extreme, if we have the airway blocked off, so that there's no ventilation in the numerator, but we've got blood flow or perfusion in the denominator, then this lung unit equilibrates with mixed venous blood, and we have a PO2 of 40 and a PCO2 of about 45. And then our normal point would be about over here, our alveolar PO2 around 100, and our alveolar PCO2 of about 40. Now, the consequences of this ratio are as follows. As you see, it claims that a lung unit with an inequality, that is, they're not a good match between ventilation and perfusion, won't be able to keep arterial PO2 as high as a lung unit that has a good match, and it won't be able to keep the arterial PCO2 as low as a more homogeneous lung where the two are well matched. So let's just focus in on the arterial PO2. Why would a ventilation perfusion inequality or a poor match not allow you to maintain as high an arterial PO2 as a lung unit where the two are well matched? Let's look at this one over here. The ventilation-perfusion ratio is infinite. We have ventilation, but no perfusion. In this case, the alveoli have equilibrated with room air, and they have a high PO2, but there's no blood flow to carry the oxygen away. So this lung unit wouldn't do you any good in maintaining an arterial PO2 as high as possible. Its PO2, to be sure, is high, but there's no blood flow to carry the oxygen away and add it to the arterial blood. Let's go over here and look at this ventilation-perfusion ratio of 0. Well, in this case, you're not ventilating your alveoli at all. It equilibrates with the concentration of the gases in mixed venous blood, and the mixed venous blood has a PO2 of 40, and this blood is just flowing through there with a PO2 of 40 and then mixing into the arterial blood, bringing it down. So this lung unit constitutes a shunt. It's just shunting venous blood over into the arterial side and contributing oxygen at a very low concentration. So neither this lung unit with a ventilation-perfusion ratio of 0, nor this one with a ratio approaching infinity would do you any good in helping keep up the oxygen level in arterial blood. What was the other conclusion? Well, it says that a lung unit with this poor match between ventilation and perfusion wouldn't be able to keep the arterial PCO2 as low as you'd like. Well, start off with the ventilation-perfusion ratio of 0, and again, we have no ventilation, but the perfusion is going on. The mixed venous blood coming in with a PCO2 of 45 is just being shunted through the lung and going into the arterial blood. That's not helping you keep it down. Then we go over here and look at the ratio approaching infinity. We've got ventilation going on, but no perfusion. Well, we have a CO2 approaching that of room air, which is 0, but no blood flow going into the arterial blood. So it's not making any contribution either. So neither this lung unit nor that one would help you keep the PCO2 in arterial blood as low as it normally is. And then finally, the last of the consequences is that a poor match between ventilation and perfusion increases the difference between the PO2 in the alveoli and the PO2 in arterial blood. And this is one of those things that is actually reported to the physician and the respiratory therapist. When you go to the hospital and have an arterial sample drawn because your health is in such poor state that you really need to sample arterial blood and find out what your blood gases are and what your pH is and so forth. One of the things on the little slip that's reported is the AA difference. the big A, little a difference. And so ordinarily that's a pretty small value, maybe between 5 and 10 millimeters of mercury. But if you have certain types of pulmonary disease that cause a poor match between ventilation and perfusion, that will increase the difference in the PO2 between the alveoli and the arterial blood. Yes?
I can change tapes.
Okay. A model of what we might be able to use to understand how this ratio of ventilation to perfusion can affect the concentration of gases in the alveoli. And so here, what I've asked you to imagine is that you've got a bucket of a powdered dye. And this contraption here is filled with water, and the water is flowing through it. Oops, what we need to do is mix it. Let me put a propeller in. So we've got a propeller here spinning and mixing this. And so V dot can stand for the rate at which you're pouring in this powdered dye, and Q dot can be the rate of water flowing through here. Well, in a steady state, if you're pouring in this dye continuously and the water is flowing through here continuously, then the rate at which you're pouring it in is the same as the rate at which it's leaving. You're in a steady state. You're pouring it in at a certain rate, it's leaving at a certain rate. But if you pour it in slowly, then the dye in this compartment will be fairly dilute. So its concentration is going to depend on V dot, the rate at which you're putting it in. But if the rate at which you're putting it in is small compared to the water flowing through, diluting it, then the concentration will be low. Now, if you pour it in faster, it's still going to be leaving this just as fast as you're pouring it in, but the concentration will be higher. And so for every unit volume of water leaving, there'll just be more of the dye in it. So that's essentially how this ratio of ventilation to perfusion affects the concentration of gases in your alveoli. Now, our next topic are shunts, because what we've already seen is that some lung units can act as shunts, but actually we have some normal shunts. The coronary arteries and the bronchial circulation constitute some normal shunts, and over here on the blackboard I've elaborated on that a little bit. The coronary vessels, some of them drain into Thebsian veins and go on into the left ventricle. That essentially bypasses the lungs. So you would have venous blood taking that route and appearing in arterial blood. Now, one of the things I told you in a previous lecture was that the bronchial circulation is actually a portion of the systemic circulation, and it supplies the major airways like the trachea. And in that case, the bronchial circulation drains into the so-called bronchopulmonary venous anastomoses. I can't ever remember that either, so I always just jot it on the blackboard. And they drain on into the pulmonary veins. So the pulmonary vein has the oxygenated blood coming from the lung, and this venous blood mixes with it. But fortunately, under normal resting conditions, relatively little blood takes this route. And so if we were to calculate the shunt flow as a fraction of cardiac output, it'd be a pretty low value. Around 2% of cardiac output is going through these shunts. Now let's look at what effect a shunt would have. And to do these calculations, I sat down with my computer and a fairly sophisticated model, and I calculated what effect it would have if you were to mix venous blood with arterial blood because of a shunt. Now, I mentioned before these congenital abnormalities. My youngest grandson was born with a ventricular septal defect, and that means there was a little hole in the wall between the right and the left ventricles. Now, in this case, everything worked out for the best. We had a very astute pediatrician who noticed it almost immediately after birth, and kept a close eye on it. And nowadays you can take little Doppler devices and put on the baby's chest, and you can actually get an image of blood going through these little shunts. And if the case is serious enough, you go to cardiac catheterization, measure oxygen levels, and try to figure out how much blood is really going through the shunt. In the case of my grandson, it was a small one, and even though you could hear a murmur produced by it, we just waited for about a year and it closed up all by itself. So the kid never had any ill effects from it whatsoever. Now, in this example, what I did was I calculated the effect of a shunt when we have a pretty good sized one. I'm hoping you can see that with the blue background. So let's look at this first line here. This first row would show the oxygenated blood in the pulmonary vein, and it's going to be almost 100% saturated with oxygen. If there's a normal concentration of hemoglobin, then in the form of oxyhemoglobin, it'll contain 20 milliliters of oxygen per deciliter. We'll have it flowing at a usual cardiac output of 5 liters per minute and a typical PO2 of 100 millimeters of mercury. So that would essentially be the blood going into the systemic arteries after it's gone through the lungs. Now, here is the shunt that's being added to it. Now, the shunt is venous blood that's not going through the lung or not going through effective units of the lung. It's going to have values that are at the venous level. It'll be about 74-75% saturated. It'll contain 15 milliliters of oxygen per deciliter, and we'll let about 1 liter per minute flow through these so-called shunts. And it'll have a PO2 of about 40. Now, when we mix the oxygenated blood coming from the lung with the venous blood that has relatively low oxygen in it, you see that pulls down the systemic arterial saturation. It should have been at 98, and it's dropped it to about 94. And here, in terms of oxygen content, it should have been up here at about 20, and it's pulled it down to about 19.6 or so. And of course, what's interesting is that in the case of a shunt like this, you now have blood flow in the systemic and pulmonary circulations at different rates. Normally, the lungs, the systemic circulation is getting exactly the same 5 liters as the systemic, but because of this shunt, we have a greater flow than before. And the PO2, instead of being up here at nearly 100, it's pulled down to 71. So you can have shunts that are holding down the arterial PO2 because that blood is not effectively being oxygenated in the lung. Now, here's a trick that can be used to determine if you have a shunt in a patient and or an appropriate clinical setting to put this to use. Now, when we plot the oxyhemoglobin dissociation curve before, you saw that it was a nice, smooth S-shaped curve. But in this case, we have plotted the oxyhemoglobin dissociation curve over a very wide scale that goes up to 600 millimeters of mercury, and so that makes the curve look more or less rectangular. Now, how would you get to 600 millimeters of mercury? Well, breathe pure oxygen. So what would the diagnostic test be? Well, if you know what the oxyhemoglobin dissociation curve is like, then what you would expect is to have an arterial PO2 of about 100 and an oxygen content up here at about 20 or so. Now, if you ask this person to breathe pure oxygen, you know that you're already on a relatively flat portion of the dissociation curve. So what you would expect breathing pure oxygen is that the PO2 would go way up like to 600, put you up here, but the oxygen content would not increase that much because you started off at about 98% saturation and you didn't have far to go. You couldn't increase the saturation much more because you already were at 98. So ordinarily you would expect that if the patient didn't have any kind of shunt and you gave him pure oxygen to breathe, it would cause a small increase in oxygen content, but a big increase in PO2. However, if he did have a shunt, the PO2 wouldn't go up so high because of the shunted blood that has a venous level that's being mixed with it. So the PO2 wouldn't go way up like that if that shunt is present. And it turns out to be a fairly sensitive way of detecting a shunt. Now, we talked a little bit in an earlier lecture about dead space, and the way we started off talking about dead space was that you could think of the major airways, the trachea and its branches, as constituting anatomical dead space, and that's easy to understand. Big, thick airways don't exchange gases with the blood. So there's an anatomical dead space. But there's also a physiological dead space, and physiological dead space would just be those alveoli with low ventilation to perfusion ratios. So alveoli or lung units with low alveolar ventilation ratios would constitute what we call physiologic shunts. And as I mentioned earlier, it's possible to quantitate the physiologic shunts by just making some measurements on blood samples, and it's usually done by expressing the ratio of the shunt flow to total blood flow or cardiac output. And I've got some figures you might want to jot down and just try out. If this CiO2 stands for the concentration of oxygen in an ideal capillary, a pulmonary capillary, you can put 20 in there. And then if this is the actual arterial concentration, put in about 19.9 there. Then again, you see the ideal capillary's oxygen concentration of 20 and subtract the venous of 15. If you do the math, you'll get what I told you before, 0.02, which means that the percentage of our cardiac output that's going through shunts is about 2% ordinarily. So that's what that equation can be used to do. You calculate and express the physiological shunting by using the ratio of the physiological shunt to the total cardiac output, and using the values I just gave you as examples, that ought to turn out to be 0.02 or 2% of the cardiac output. So ordinarily, in healthy adults, you don't have all that much of a shunt unless there's some sort of pulmonary disease at work. Similarly, we can calculate dead space, and the physiologic dead space is produced by those alveoli that have high ventilation to perfusion ratios. And again, go back to that first schematic that shows the 3 different lung units with ventilation perfusion ratios of 0 and normal and infinite, and reason your way through that, and you'll see that physiologic dead space is indeed created by the alveoli with high ventilation perfusion ratio. This may have a mistake in it in your notes. You don't need the dots. In this case, it's not a flow, it's a volume. And so we typically express the ratio of dead space to tidal volume, use that as a way of quantifying physiologic dead space. And it's actually something that's fairly practical to do. You can measure the arterial PCO2 in expired air, and then use this equation, and it will give you the ratio of the dead space to the tidal volume, and that's a good way to look at the physiologic dead space. Next time, we'll take up the control of ventilation, and we'll do some computer simulations. Today was certainly a unique experience for me. I've been teaching here for something like 33 years, and this is the only lecture that's ever been interrupted by a fire. I'm going to start my weekend. Again, I'd like to reiterate my offer. If you get to the point where you start looking at the old exam questions and you don't understand why a right answer is correct and a wrong answer is wrong, email me, but please be specific. Either give me the whole question or make sure I know where to find it in the documents that we put on the blackboard for you to study. When is our lecture? Monday? Is it 8 o'clock Monday morning? I'll see you then. Have a good weekend.